Hey there, David from Bodyworks here. Today we are going to talk about TMJ, which is a temporomandibular joint dysfunction, pain in the jaw. So let's get to it. So, TMJ is a very common condition, whether it's the more advanced version of actual joint dysfunction right in the joint of where your mandible, which is your jawbone, meets your skull. There is a joint there. To just more generalized jaw clenching patterns that cause lots of pain, headaches, and potentially frozen jaw stiffness. So we're going to cover all of those sort of spectrum of tolerable to really intolerable conditions, and then what massage therapy can do and what specialized massage therapy, because we actually do some very advanced work here at Bodyworks DW that I learned a long time ago, practice all the time, and then train most of my therapists on. So we're going to kind of get into first the anatomy of the jaw, and then how just working on the jaw itself is not really going to solve the problem, and how it relates to the musculature of the rest of the body and what we might do in sequence, and then go over the specifics of the muscles, how we can use very specialized inner mouth work, which is something I specialize in, using gloves obviously, to get at muscles that are only inside of the mouth, that are only accessible that way, that can provide a profound relief for TMJ. So on our website, we have a pains and condition page right on the site about TMJ. And in that, we can look at some very specific stats. So I'm just going to pull this up so I can read it. So TMJ issues are extremely common. 60 to 70% of people show signs of dysfunction, and 5 to 12% develop symptoms that are full-blown TMJ joint pain. They often come from a mix of tension patterns, not just related to the jaw themselves, but also related to the neck, shoulders, and back, and even hips, knees, and ankles, feet. A lot of people, especially if they have neck and shoulder tension, that tension will feed right up into the jaw, and then the jaw locks. And then when you try to work on neck and shoulder tension, let's say you come in for neck pain, if we don't get the jaw to move and release, sometimes that will keep the neck and shoulders from ever really improving. They might feel better, worse, feel better, worse. And so when I'm working with anything in this entire area, I'm gonna wanna work on each of those possible areas, whether it's shoulder position, neck mobility and movement, and jaw position, movement, and whether it's locking or it's got some freedom to it, and then even up into the head muscles and fascia. Cool fact, this big muscle here called temporalis, which we think of as mostly related to headaches, and this is a headache area. This is actually a big jaw muscle that moves and closes the jaw. And so all of these areas are very interrelated, even though the jaw technically only has 4 distinct muscles that move the jaw. Let's go over some of the basic anatomy here, and I'm going to start with Trail Guide to the Body, one of my favorites. I've had this particular copy since 19 years ago when I started massage school, almost to the day. First week of January, we're in the second week of January 2026. I started the first week of January 2007. So I've had this book a long time, but it's still really great and a really easy way for more of a lay person. If you're ever interested in learning muscles and anatomy, this is where to start, I think. Okay, so I have pulled out muscles of the head, neck, and face here, and you can see that there are a lot of possibilities. Okay, so I just mentioned temporalis. That's this big muscle right here, which comes down and feeds into the upper part of your mandible, which is your jawbone. So, actually, let's just go over basic jaw, which is that you have 2 big structures to think about. You have your skull, which technically has a whole bunch of bone parts to it here, right? There's different little zones of the skull that are connected by these very, very tight suture joints, they're called. And those should be pretty solid and unmovable, but they do have a little bit of give to them, which is where craniosacral therapy can actually maybe provide some relief. And you can see on the back of the skull right here, you've got this big occiput bone and these suture joints, and the suture joint way up on the top that reaches around to the frontal bone. You don't need to know all these names, but really you can just think of the big part of the skull here as one piece, and then the mandible, which is the jaw, as a different piece, right? We're not going to include the teeth in this. And this little spot right here, and I'm kind of hoping Harry can really zoom in on it. Maybe I'll even bring it into the front camera here. That is the TMJ, the temporomandibular joint. And the J, sometimes you hear people say the TMJ joint, which is kind of a funny thing because the J in TMJ actually is for the word joint. So if you say TMJ joint, you're really saying joint twice. So it's the temporomandibular joint. Okay, so that gives you an idea of the bone structures. All right, before I move on, actually I'm going to go a little bit deeper into the bony structures of the skeleton here, because I think it's super relevant here to understand what's really going on. So again, this is the overall view of the head, neck, and collarbone, and you can see how the skull sits on top of the cervical spine here, and the mandible attaches to the skull and gives you some movement right here. And almost forgot, but there's below the jaw this floating bone called the hyoid bone, which is a sesamoid bone. Sesamoid bones are not attached to other bones, and you can see in this structure that it sits on top of your trachea and esophagus, but doesn't actually have attachments to your spine or your mandible or your skull. So it's literally free floating on top here. However, there are a whole bunch of muscles that attach your hyoid to your jaw, so that's going to be super relevant to TMJ. Okay, so I won't go through all the different skull bones because that's a little bit beyond, other than to say that you can see in this image how this sits in here, and that's where the angle opens and closes, and then you have this little bony structure here that keeps you from actually biting down too hard to crush your teeth. And so that's what that post right here is actually for. And then the hyoid again here you can see. Okay, this is always fascinating to me. So here you see all of these different skull bones on the outside, and they have these suture joints that fit them together. Those all fuse in your teen to 25 years. Some of these suture joints don't actually fuse until you're 30 on some people. Obviously they're functionally fine, because if they were too soft, like when you're a baby, you would have a hard time walking around the world. But inside of your skull, facing this way, is a beautiful bone called the sphenoid bone that looks like a moth almost, and you can see that in here. And that actually sits this way inside, and it's where the brain sort of like rests on the front of it. You know how the brain sort of has that shape to it, where it's like a big thing. This part here rests on top of the sphenoid bone, and then has all the cranial nerves that go to your eyes, your jaw, your ears. They all kind of come out of the sphenoid bone, which is why it has all these little holes in it. Okay, so then here is the mandible itself. And again, here you can get a little bit more in detail on the top camera. And so here you see that bone, this front goes out to where your teeth come together, and this post back here feeds into a joint in your skull. and there are these different ligaments that hold it together just like any other joint in the body. Okay, and then coming in just a little deeper to that, this is sort of a cross section of that. And you can see how here there's supposed to be a disc like your cervical discs or your lumbar discs or your knee cartilage, let's say, or your medial and lateral discs on your knee. This is a very similar type of structure in that it's got some cushioning, but it's also dense enough to last you chewing over and over and over and constant grinding in there. That is meant to be a cushion between those two bones so that you don't get arthritis of the bones and they don't just wear each other down. That can have some issues with, like, full-blown TMJ. Often that will either have slipped out of place, which is one issue you might run into, or it will wear down and degrade to the point where you do have osteoarthritis of the two bone structures, and every time that you're opening and closing your jaw, you're grinding bone on bone, which is as bad as it sounds. And so that is a structural problem for which massage obviously can't replace your disc or fix your disc. It can only really deal with the symptoms of pain that that causes and hopefully decompress the joint and loosen the muscles so that it's not so jammed in there and so grinding. But that is more of a structural problem, again, that really is full-blown TMJ. Most people don't have that issue. Most people are dealing with much more generalized muscle tension, which is something we can do a lot for. Then we get into the hyoid here. The hyoid sits right on top of your trachea, and your trachea sits on top of your esophagus, which goes down also into your lungs as well. And so that structure here has the hyoid bone sitting right on top of it. And both the trachea and the hyoid bone are actually free-floating in the neck, and you can gently shift them around with no problems whatsoever. They're only held by soft tissue. This is a top view of the hyoid, which sort of looks like a horseshoe like that. And the horseshoe goes in this way and sits on top there. I think that's enough about bony structures and cartilage and all that. Let's get into the muscles, the things that we can generally do a lot for as a massage therapist. So there are really only 4 technical muscles that move the jaw, and I'll go into those first before then showing the related ones. So there's temporalis up here, masseter, which is the big muscle here that everybody wants to self-massage. And then inside the mouth we have the medial and lateral pterygoids, spelt like pterodactyl, PT. And those are side to side and protraction chewing muscles. And so let's talk about the movements of the jaw. Obviously you can open and close your jaw, and you can also shift side to side when you're chewing, but the last one that people forget about is protraction, retraction. So protraction would be this, and retraction would be this. And so you can actually move your jaw forward and backwards. Those pterygoid muscles, which we can only get at from inside the mouth to do any actual manual work on, do side to side and protraction, retraction. They don't open and close. Open and close are masseter and temporalis. Are really opening is more hyoids down here that pull the jaw down a little bit, and then gravity also allows you to just, if you let go of the closing muscles, your jaw will open. And so all of these different muscles have an effect on the position of the jaw and the function of the jaw. And for a lot of TMJ clients, what happens is they've really lost the ability to shift side to side comfortably and protract, retract. And so getting in on those pterygoid muscles and giving them a little bit of work, and I'll say, when I say little bit, I mean they're tiny little muscles and they actually really don't need much. They just need to be reminded in your brain that they exist, that they're muscles, and that they could act like more like muscles than tendons. Oftentimes they get frozen. I was actually at the dentist this week for cleaning and was like, oh God, I'm gonna need some inner mouth work to undo all of the insane tension that causes you just trying to hold open your jaw for half an hour to an hour. Okay, So again, temporalis over here, big muscle. Masseter over here, giant, one of the strongest muscles per square millimeter that you have in your body for obvious reasons. If you can't chew, you can't live. Here, under here in this, so here we have SCM, this giant neck muscle here that rotates your head to the opposite side, and you can see it tighten that way, and also pulls your head forward. That feeds up right here to this bump on the back of your skull called the mastoid process. So it's not a direct jaw connection, but it absolutely will feed fascially into your jaw muscles and affect them. And so you can see the front view here of SCM that kind of comes at an angle. And then beneath that, here is the hyoid bone floating on the trachea. And these are called the suprahyoids. And I won't get into each and every one. They all have names, but that gets really complicated. But you can just think of the hyoid muscles above the hyoid bone and the hyoid muscles below the hyoid bone. The ones below come down, and some of them attach to ribs 1 and 2. One of them, very strangely, comes all the way out and attaches to your shoulder blade. So there's actually a direct connection between shoulder tension and jaw tension. And then some here are attaching to the clavicle a little bit. Well, they shouldn't actually attach to the clavicle, but sometimes they'll adhere to it. Synergists, muscles working together. You can see how here SCM is turning and rotating the head, but that's all going to have an effect on jaw as well. So here we talk about elevation or closing of the jaw, those masseter and temporalis. Depression, which is opening of the jaw. Oh, I almost forgot a really big giant muscle. So on top of everything else I just showed you, you have a big sheet that is very large in surface area but super thin and not very strong called the platysma. And that attaches all in here, comes down and attaches all the way to the top of your chest and your clavicles. And so that actually does help open and depress the jaw along with the hyoids. And then you've got protraction, which is pushing forward. That's going to be your lateral and medial pterygoids. And retraction, which is going to be a muscle called temporalis. Well, temporalis slightly retracts. And the digastric, which is in here, that's attached to your hyoid bone. Let's see, does that cover everything in this book? Yeah, okay, cool. More than you ever wanted to know about TMJ, maybe? Oh, wait, I got one more posted on this book. Oh, here we go. Okay, so this is a better view of the classic 4 jaw muscles. And so here is masseter, this big giant muscle right here, which attaches to this zygomatic arch, which is part of your skull, and then wraps around the lower angle of the jaw here. And when it tightens, it closes everything. When it loosens, it lets it open. Okay, so that is out here. Here's temporalis again, which you can see attaches to that post that comes up here. So it doesn't actually attach directly to the joint itself. It attaches here to help give it some leverage to pull up on the jaw. It also, if you can imagine that this is the muscle and this is the attachment, when it tightens, it's going to pull that slightly backwards and cause that retraction to happen. Okay, then we get the suprahyoids and the digastric. So the suprahyoids are all in here and attaching to the hyoid, but there's actually one that comes, the digastric, that comes way back to here to the mastoid and comes from the hyoid. And if you can imagine that tightening, it's going to pull the hyoid backwards, which is then going to yank on the suprahyoids and pull the jaw backwards. And you can see that right here. So this is the digastric back here. That's attaching to the front of your hyoid all the way from here up to there. And then here is the digastric anterior. And so the hyoid bone sort of floats between those two anterior and posterior digastric muscles. and the tightness of them from one to the other is where the hyoid bones will sit between those 2 points. And the 2 points are here and here, and this is the third attachment, the hyoid right there. And so if this side's too tight, it's going to pull the hyoid forward a little bit, maybe push the jaw out a little bit, like that. And if this is too tight there, it's going to help retract and pull the jaw backwards a little bit. Here we've got a really nice view of the platysma, this big sheet of muscle that comes all the way down into your chest. And you can imagine if you were just to pull down on your chest and stretch up and push your jaw, you would be stretching that whole platysma muscle. One thing about it to know is even though it looks gigantic, because it's a very big surface area, it's quite paper thin and very, not super strong. Thin superficial sheet is how it's described here. And then inside the mouth, we've got these lateral and medial pterygoids. And so the medial pterygoid attaches from in there and up into your skull. That's very hard to get at. Basically, all we can do is come down here and get a little edge of the attachment down there, but the other one is up underneath, inside of your palate, under your tongue. And so that would be very hard to get at, the belly of that muscle. So you can just kind of come down and get the edge of it. Whereas with the lateral pterygoid, that you can go right up in behind your back molar and get right into the middle of it with a finger. And that can, both of those can provide a ton of relief. And that is the sort of inner mouth work that you hear. It's not the only set, but those are the 2 major structures we would work on inside the mouth. Now, when I say all of that, it sounds like we're going to be spending a whole 60 minutes inside your mouth. That's definitely not going to happen. Honestly, the work that we do in here might only take a few minutes tops. We would always put on gloves to do that. We use non-latex, non-allergenic gloves at our studio. We actually keep them in all the treatment rooms because I honestly do this work multiple times a week on multiple types of clients. Often for clients that aren't really complaining of jaw work, but they notice they have migraines or they've got neck and shoulder tension that's chronic. We often will pull out the gloves and do this work if a client is okay with that idea, because it can be super duper impactful and very helpful. Now, just to give you an idea of what that would look like or feel like, essentially what we're really doing is contacting the edge or the point of the muscle that we want to, doing pretty light pressure. And when on camera I look like I'm doing that, that's probably about the pressure that I would be using, very little. I'm not like that putting a lot of pressure. That will still feel like a 6, 7, 8 on your intensity scale, just touching it like that. They're very tiny, very sensitive little muscles, so very little pressure will create very intense sensations. So we want to be very precise about our work. We're going to come in, we're going to contact the muscle. That in and of itself is going to feel like, whoa. Then when that calms down, we might then ask you to just start trying to mobilize your jaw. I might ask you to open wider a little bit. That will increase the intensity all in of itself. If that starts to calm down, then it might ask you to move your jaw side to side while you're doing that. Again, that will be intense, just me doing that much pressure, not even moving my finger, not doing anything. And then last but not least, I'm gonna have the client protract and just help stretch that out, because most people are stuck in retraction. And that also will up the intensity level. So even just that much pressure, and I'm not joking at all, that this relaxed view of me just pressing lightly into the table is how much pressure it would take to cause a 6, 7, 8 on your whoa scale. And then moving your jaw around pins and stretches the muscles. So essentially I'm pinning it down, you're stretching it by moving your jaw. You're in charge of how much you want to do that or not. And the more that you can do it, the more your brain realizes how frozen those muscles have been and rethinks, oh, right, that muscle should move and have these movements available to it. And so that in and of itself can be super impactful, very profound, and very changing of the whole tension structure of the head, neck, and shoulders for not just TMJ clients, but also neck pain clients, headache clients, migraine clients, shoulder pain clients, all of it. And that whole process of just working on this point, hold, move around, this point, hold, move around, then going to the other side and doing that point and that point. So 4 total points and areas, might be 5 minutes tops, maybe not even. And half of that 5 minutes is probably giving you a break and letting you relax between each one of these, because it can be quite intense, even with a tiny, tiny bit of pressure, but also once it's done, everybody's like, oh my God, I had no idea this giant bubble of tension was like sitting on top of my head, neck, and jaw, and now I feel like it popped, and now I feel like way lighter, way easier. So it's totally worth doing if you're up for it. It's optional, it's certainly not required, but it can be super impactful, and why I have gloves in all the rooms, why we do this work all the time. I think we got that book covered. So a little bit more now, just to give you an idea about how that's all just way up in here, but this all relates to everything below it. So we got Anatomy Trains by Tom Myers, one of my Bibles. And I wanted to show you a couple of ways that this whole set, these muscles really connect all the way through the rest of the body. So we'll start with his superficial front line, which is his terms. And you can see how this starts at the top of your feet, runs up your shins, runs up your quads, and then it uses the pelvis as a sort of lever to connect the lower chain to the top chain. And this top chain is really important for headache, neck pain, jaw stuff. Anybody comes in with those issues, I'm going to want to work on lengthening this chain in addition to other work. And the reason is, you can see that your rectus abdominal muscles, which are your 6-pack that sit on top of all the abs, that comes up and feeds through the fascia on top of your sternum, and then comes up into these SCM muscles, and those connect with a band of fascia all the way around the back. And so if you remember the digastric, which attaches here, so that's going to get affected. The temporalis, even though it technically doesn't connect here, fascially will be affected by all this. The other reason is that this chain, when it's tight, will pull your head down and forward. And that in and of itself, I can even feel the tension in my jaw just showing you this posture. And so while I could absolutely free up the jaw, if I don't bring the head back up and in a relaxed place on top of the spine, the jaw tension is just never going to fully let go, no matter how much I work on the jaw muscles. So releasing, even starting way down here, but even in a session, I might start at the knees, come up the quads for 5 minutes, come up here, and then before I ever get to your head, neck, jaw, shoulders, I would want to release this front line. All right, so then we have the deep front line. All right, and so that's on the surface. This is more deeper muscle tissue. And so here we have, beneath the shins, we have what's called the interosseous membrane between the bones of your lower leg. That I'm probably not going to work directly on. It's certainly not in session 1. But then we have the adductor muscles, the inner thigh muscles, which then weave fascially and up into psoas and iliacus, super important muscles. And then there is this sort of fascial muscle chain up the very front of your spine. Your QL back here is also part of this whole thing, up into diaphragm. And then that feeds up into these deeper neck muscles. And so let's go over those in a little bit of detail. So here we've got that all feeding up through the trachea into the jaw. And so here we have the infrahyoids, the omihyoids, and then that comes up and into digastric and masseter and temporalis. I've done this one on camera before, and you can really see how this whole thing is actual muscle tissue dissected out of a cadaver, and how the very toes all the way up this chain connect to your tongue. Kind of fascinating. Psoas, super important muscle. Very few clients ever get off my table without psoas work. That's going to weave up into diaphragm, which is then going to come up the very front of your spine into longus colli, which is a whole different, very specialized work that I do as well, where you can slide the trachea slightly out of the way and get right onto this longus colli muscle, optional, but also very impactful. And then this whole structure here, so diaphragm comes up into scalenes and into that longus colli in the front of your neck, and all of that feeds up into the jaw. For the LMTs in the bunch, this is a fascinating muscle here. This is called thoracis, and I only discovered it years ago when I was creating my ribcage workshop. Because it's not one we generally talk about, because it's not one you can generally get your fingers on to work on, because this view is not the outside, this is the inside of your rib cage. And so behind your sternum, kind of coming up behind it and into the ribs, you have this web of muscles that almost looks like a spider in here. It's a very cool looking muscle. And that is generally thought to be inert by science. It's more of a scaffolding muscle, just helping hold the structure in place. But that's part of this whole chain that we're talking about with the deep front line as well. And so that has a slight relation. You can potentially affect that with the attachments on the xiphoid process, but that's very, very specialized work, part of the ribcage class. Okay. Coming up into the jaw, again, we have these infrahyoids above the hyoid bone here that come and attach to the mandible, and also the the posterior belly of the digastric to the mastoid process. And then you can see this really cool view in here from below, and from the see-through view here of the pterygoids. So from below, you can really see this is the medial pterygoid, and this is the lateral pterygoid here, way up in there behind the back molar. And the lateral pterygoid is the one that you can really get your finger on the muscle belly itself. And the medial, you can really only get the attachment down here, because as you can see, that comes up behind the palate. It's not accessible from inside the mouth. Okay. One last view before I get into just sort of a thank you. This is Rolfing by Ida Rolf, one of my other Bibles, one of Tom Myers's Bibles. So last but not least, I wanted to show this side by side, because it's really just sort of helps show how even if you have an issue up here, the whole rest of the body affects it and is related to it. And so if you want these issues up here, not just to feel better for the short term, but to really change and feel better for the long term, yes, we're absolutely going to work directly on the stuff that's bothering you up here, but over time we have to include most of the rest of your body and get freedom and realignment in the rest of it in order for that relief that you get from the sessions to actually stick. And so here, this is before 10 sessions, and you can see how the rib cage and the back are so tight that the rib cage goes way behind this person at an angle, and then the head and neck come way out in front at an angle, right? And you can absolutely imagine that this person's is going to have some complaint up here. Could be jaw, could be headaches, could be shoulder pain, could be neck pain, could be all of those things, or any and all of those things in a lovely rotating pattern. Now, in order to get to this nice, much straighter, much happier, much easier side view, they didn't just work up here. So I'm going to read this caption, right? The man on the left is approaching 70 and looks aged, tired, disheartened, ill. Even visual examination, however, suggests that there is something that can be done to improve the situation. Reorganization at the hip joint will in turn support the upper body. And what we're looking when we say support is that there's something that this rib cage wants to then naturally float on and sit on top of, literal support. Right now the shoulders are unsupported by anything below them here. And so reorganization of the hip joint will support the upper body. The picture of the same man on the right after 10 60-minute sessions confirms this interpretation. You know, this is before, this looks way easier after. And then this goes on. But let there be no mistake. If help is to be had through structural integration, it was what Ida Rolf called her work. My work is very related to that, even though technically I'm a massage therapist. It is not possible to start locally at the hip joint. To really induce appropriate change at the hip, it is necessary to start with the feet and ankles, to progress through a sequence that at moments may seem far from the weak point of the hip and far from the weak head, neck, jaw area. Nevertheless, this is the approach and the sequence necessary to effect change all the way up the body, right? And so what they're really saying is to get this comfortable up here with all the stuff that you might be complaining about, we actually need to reorganize everything below it so that it sits and each level of your body is supported, and that will allow all the muscles up top in this area to relax a lot more because they're not trying to hold your head up. In this first view, this person's jaw, neck, shoulders are working all the time just to keep his head from falling completely forward and to keep his eyes level with the horizon. In this, that sits much more on top of every other structure beneath it, which means that it's balanced in gravity. It has bones under it. The skeleton itself is supporting the head, neck, and jaw a lot more, and therefore the muscles can relax more and they have much less work to do. So that's just to give you an idea that even after we do very localized, specialized work in this area, inside the mouth, in here, behind here, maybe for TMJ, up into here, in order to get that relief that we provided you to actually last long term, we're going to want to work, you know, potentially all the way down to your feet and ankles. And I've actually done tons of sessions where I only work from the knee down for an hour and watch somebody's shoulders drop a 1/4 inch to a 1/2 inch, and never touching them. Watch their head, neck, and jaw lift and be lighter, just working on the feet and ankles and lower leg. And so we aren't going to do that necessarily to you the very first session you come in. We're not going to just spend an hour from the knee down never touching up here, because that isn't what you want out of our sessions. You want some immediate relief. But once we give you that immediate relief, we're going to want to work on these different areas to get it to stick long term. So just that, I think, really helps sort of show in a very clear way what the kind of structure of sequence sessions that we're talking about here at Bodyworks DW can potentially produce. And just so that you have an idea, this person is 70, right? And so if they can make this much of a change through the work, then if you're younger than that and more resilient, right, easier bouncing back, more quicker recovery, then you're far more likely to get this kind of result out of even, let's say, 5 to 8 sessions. And so that's a general overview, general to very deep overview of TMJ. So in closing, I just want you to let you know this is kind of work we do all the time here at Bodyworks DW. We really do specialize in it. I especially have done this work multiple times a week with clients for years, 18 years now, 19 years. And I've trained most of my staff directly on this, and some of them have their own experience with it and bring that to them. So you can absolutely trust that this is the kind of work we do here all the time. So if you're dealing with TMJ, jaw clenching, jaw pain, tightness in the head, neck, shoulders, migraines, headaches, tension headaches, that's all stuff that we do here all the time. So if you're in New York City and want some relief, take a look at our website, look in the description below, and book a session. We'd love to help you out, and hopefully we get a chance to work together.